What we're here to talk to you today about is the topic of interprofessionality and what your role would be on a care team caring for medically fragile children. And we're here to talk to you a little bit about what happens with abuse and neglect and what happens when you are the team member, when you are the healthcare provider that is taking care of a child that has been abused or neglected, and you're also coming into contact with the parents. A lot of times we work with parents that maybe are trying to get their kids back, or maybe they have supervised visitation, and the goal is to get the child back to them. So as healthcare providers, we will be working with that family to try to help them to provide the best care for their children. The issue with that is that sometimes we may be a little angry about what we read in the chart before we go in and see the patient, And so we're going to talk about some techniques that you can use to try to kind of push past that and go ahead and deliver the best care that you can in the most non-judgmental way that you possibly can to promote health for the patient and for the entire family. So we've entitled this, What's Wrong with These Parents? Pushing Past Judgment to Care for Families in Need. And this is after lessons learned from the Interprofessional Pediatric Advocacy Program. So I'm going to tell you a little bit more about that too. And Kara might be able to help us because she was actually a student that participated as a team member and volunteer for the Interprofessional Pediatric Advocacy Program. So she can tell you some of the techniques that she used when helping her family as well. So this is our little disclaimer. Nothing in here is intended to be legal advice. This is just for your own education and pleasure and entertainment, Okay, so the reason that interprofessionality and interprofessional education is important to us is that we realize now that training students together, healthcare profession students together, leads to better outcomes for families and for patients. It leads to safer environments, and it makes it a platform to where students are able to communicate better with the healthcare team when they first graduate. And that is very different than the way that I was educated and the way that Mary was educated. When we all went to different classes, different schools, you didn't come across anyone else on the healthcare team until that very first day that you showed up at clinical or on your new job, And then you were expected to be able to work together very well, very functionally. And sometimes it took a long time to actually get to that level where you could respect each other, trust each other's opinions, and give the best care for the patient. And so you are actually in school at a really great time because we've realized that we can care for our patients better if we're trained together before we actually get out there and start working together. So that's why you're hearing so much about interprofessional education right now. And of course, the Institute of Medicine, really they're the ones that do a lot of research and dictate to us what are the methods we can use to make our patients safer and make our community healthier. And so what we have learned through a program that we've been implementing here at the School of Nursing, or UTMB started out in the School of Nursing, but now we use this as a clinical experience for the School of Medicine, the physical therapy students, occupational therapy students as well. And it's a program called the Interprofessional Pediatric Advocacy Program, and it's a grant-funded program. The grant is funded through the Health Resources and Services Administration, or HRSA. And the goal for HRSA is to be able, again, to educate students together on teams before they graduate for the benefit of the patient. And so what we'll be doing here is talking about interprofessional experience, what your experience has been, things that we have learned, and things that we think that you can benefit from as you move forward. So the objectives are to compare and contrast healthcare provider roles, discuss strategies to implement an interprofessional care for medically fragile children and their families. I want to tell you a little bit more about what I've learned about how to train students to work together best, so that they can be very effective healthcare providers. One of the things that we do is train students with a method called team steps. And has anybody heard about team steps before? You know what it is? Okay. Has anybody heard about SBAR? What's SBAR? SBAR. What's that stand for? Situation, background, assessment, and recommendation. And when would we use SBAR? Shift handoff is one major one area that we use it a lot. What else? The documentation for nurses. And the reason that we do SBAR, that we use SBAR, is because On very hectic units, at the end of a shift, when you have a lot of different things going on, you want to make sure that there's no information that's omitted when you're giving a report, okay? It's also one way that we train nurses and nursing students to give report to physicians or advanced practice providers so that they can understand what our assessment was and what our recommendation was, okay? So we have that little S-bar, so basically nothing is left out, okay? S-bar is one component of team steps. So if you know S-bar, you already know a little bit about team steps. It's all about safety. And team steps was actually something that was developed in the U.S. military. They developed it as a way to train their, basically, they started out using it in the Navy, and they used it a lot with air traffic controllers. Whenever there's really important communication that takes place, that if there's something left out, it could injure a large amount of people, right? Like driving a huge ship, flying a plane, landing a plane. This is when they started using team steps. So after a while in the early 90s, hospital administrators, healthcare providers started saying, hey, we're having a lot of issues. The IOM, the Institute of Medicine, started saying, we've got to have a way that we can teach people to communicate better. And this was a model that was already in practice, so we've adapted it to use in the healthcare facilities, okay? All right. So we want you to be competent, and the outcomes of team competency is that you gain knowledge, okay? You have a shared mental model. That means that team members that are caring for one patient or one family, they discuss things. They understand what their goals are, and they have a shared mental model. Attitudes, you also develop a mutual trust and team orientation. And that's wonderful to have because it didn't used to be like that. We didn't work together before we graduated, and so when we graduated and got out there on the units, we really didn't know what the other person was supposed to be doing, okay? And if you have somebody that you really don't know what their role is, and you're caring for a patient and they're caring for a patient, it tends to be you don't really trust exactly what they say. Because, I mean, we all, by nature, are pretty egotistical, and so you're going to think that you're the one that knows how to do it the best, okay? Especially if you really don't understand someone. And I'll tell you, as a nurse, when I first graduated, it took a really long time to develop that caring, the establish rapport and get them to trust you, get the other team members. And I'm not just talking about the issues that go on between doctors and nurses, I'm talking about the other nurses on the unit. Just being able to say, okay, yeah, I'll hand off a patient that I really care about to you, you know what you're doing, okay? It takes a really long time to establish that. You guys have such an advantage because you're educated together, you understand what each other's roles are. We talked about this a little bit in the last session, but it's pretty common knowledge out in the public. Most people know what a physician does and what a nurse does, or they think they do, okay? Whenever you start talking to the public about other people like occupational therapists, okay, child life specialists, respiratory therapists, what are their roles? What do they really do? Dietitians, okay? There are a lot of things that we could be depending on each other more. We could be making recommendations and referrals to each other to really promote health for families in the most holistic manner that we can if we understand really what the other scope of practice is. And that's why we're so invested in this right now. We really care about it because we really want our patients to have the best outcomes. So, okay, and then as far as performance, this team competency really promotes adaptability, accuracy, productivity, efficiency, and safety. Drink so I can talk. So as far as team performance, knowledge cognitions, these are ways that we think. Attitudes are what affect the way that we feel. And skills, these are the behaviors or what we do. So we have to have a good understanding from all members of the healthcare team to really be able to understand these things. Okay, so it's so important because teamwork is one way that we reduce clinical errors. We improve patient outcomes, improve processes, improve patient satisfaction. You've all heard about these Press-Ganey surveys, right? What are they? What are these? What's a Press-Ganey survey? You're going to learn about them pretty soon. So every time you have a patient that comes into the hospital, they're going to get an evaluation to fill out afterwards, or at the clinic. Okay, I work at an urgent care clinic, and every week I get the little feedback from my patients. What did they say about me? How was their experience? Okay, and so we put a lot of thought into what patients actually think. Patients are consumers. They have lots of choices about where to go, and we want to make sure that they feel like their voices are heard and that they feel safe in our hospitals and our clinics. And so you are going to be rated after you graduate and after you get out. And so patient satisfaction is improved by effective teamwork. Also increases and improves the staff satisfaction, which helps care providers to stay in their role longer, and also reduces malpractice claims, which is something that's very important to all of us. Okay, so if you know more about your team and you have a shared mental model, you are really able to predict the needs of your team members better. And when that comes into play, a lot of times is very high stress situations. For instance, I spent a lot of years working in labor and delivery. And if you have a baby that's crashing, or you have a mom that's crashing, and you have a shared mental model with your team members, you know, you can help each other more. I would have physicians that would call and say, okay, yeah, just go, do the right thing. Because we had talked, I knew what the parameters were, I knew what they needed from me. I could call down to respiratory therapy and say, okay, I have a baby that's acidotic. They would run down, they would know exactly what to draw, what to do. You have to have those conversations before emergencies take place to actually be able to function well, okay? The other thing is it really reduces the stress on the whole team if you have a better understanding about roles. Okay, so as far as partnering with patients, we want to make sure that we consider parents and patients as partners in care, okay? And it's hard for us when we're dealing with patients that are being monitored by CPS because we already have these preconceived judgments about people if they're being monitored by Child Protective Services, right? What would you think if I told you that that my children, you know, that they were still in the home with me, but CPS was following me? What would you think? You just met me, but CPS is in my life. What's your first thought?
Not taking care of your kids.
You're not taking care of your kids, right? Okay, so you already have that judgment about me before you come in to take care of me, okay? As far as CPS goes, we are all mandatory reporters. As a healthcare provider, you're a mandatory reporter, and so you have the responsibility, the legal responsibility, to report abuse and neglect, the suspicion of abuse and neglect within 48 hours of coming into contact with a patient, or not just a patient, anybody in the community that you feel have been abused or neglected, especially children and elderly people. Okay, so what that means is that if I come in and I think that she's being abused, all right, even if I just see something that's very suspicious to me, if I don't report it within 48 hours and then later on, 3 days later, she's dead, okay, they're going to come back to me because I was the healthcare provider that saw her and didn't say anything, okay? And when they go in and look, oh, these are old bruises. What's going on? She saw you. You didn't say anything about this, okay? It can actually, it's punishable in Texas by a $10,000 fine and a year in prison. So it's a really big deal for us to learn how to assess our patients, look for subtle clues of abuse. It's not always just bruising on the face, okay? There's a lot of other things, and what you'll find out, what we found out, is that most of the time abusers don't hit people in the face. They hit them in the places that will be hidden by their clothes, okay? The thing about being a healthcare provider is that we see parts of children's bodies and adults' bodies that most people would never see. Okay, and so we really, I mean, we have a very strong burden to protect and advocate for those patients. And so we want to partner with our patients. These parents, although something has happened in their life and we don't know, people can be reported to CPS for anything, okay? For instance, if there's I have a very good friend that is a director of a summer camp. Okay, she is a master's prepared teacher. Her husband went to seminary. They are a good, strong family. They have a little boy with Down syndrome. And as you know, children with Down syndrome, they don't have a lot. It's very difficult. They're very headstrong, and it's very difficult for you to establish rules with them and for them to think about the outcome of their action. Okay, so her little boy at 4 o'clock in the morning went out of his room. Okay, he was 7 years old. He went out of his room up the stairs to his sister's room because they didn't have a top story room for him because they were concerned about this. His sister had left for college. He went up to her room with his Superman pajamas on and his Superman cape and dove out the window at 4 o'clock in the morning. Okay, ended up with orbital fractures. He had a concussion. He had to have 60 staples in his head. He was hospitalized for 3 or 4 days. I mean, just a very, very bad situation. They are not at all neglectful parents. However, you know, we can never predict at 4 o'clock in the morning if your child is going to go up and pull a Superman out the second floor window, right? So they were investigated by CPS, and they were investigated not only him, but they have 4 other children. So they investigated each one of those children. They went and interviewed people at their school. They talked to their physicians. They talked to their coaches on their basketball team. One of them took horseback riding lessons. They talked to the trainer. I mean, they did a full investigation with every child in this house, okay? So something like that, I mean, and they came back and said, okay, the children not being neglected, it was not abuse, it was an accident, it was unpredictable. But that could happen. I mean, that could happen to any family, something that's just an accident that's unpredictable. So just keep that in mind. We don't know all of the details, but we want to try to promote health as much as we can. And especially if these families are going to be getting this child back, the CPS really hopes for family preservation as much as they can. Children, even children that we have seen that have been abused, they really want to be back with their families, okay? And a lot of the families that we work with, it's not so much that they have abused their children, but they have neglected their children because of extreme poverty, mental illness, addiction. And so in many cases, it's just a matter of CPS looking at that family saying, okay, you haven't abused your child, but you have neglected your child, and that means that we still have to protect the child, all right? So what they do is they'll work with them for about a year through a program called Family-Based Safety Services, and they offer lots of services to the family to try to get them to where they can take care of their child in a safe manner, okay? So what we do with our program is we work with these families that have, all the ones that have the medically fragile children that are in that program, and we hope to get them back up to speed. So we take medical students, nursing students, PT and OT students, and we're referred cases from Child Protective Services, and that team of 3 or 4 students will stick with one family, and they follow them through the whole semester. And they do a lot of education with them. We go and do weekly assessments at the house. If they have an appointment, they'll go with them to help kind of translate what goes on at the appointment. One of the other issues with the families that we come into contact is a lot of them have a very low literacy rate. And so if you go and they have a 15-minute appointment at their doctor's office, they may leave and they told them, okay, here's what we need you to do. Your child's on a sliding scale. We need you to change this. We need you to do that. And they really didn't have any idea what they said when they left, okay? And so when we go with them, sometimes we'll go out and sit in the lobby and actually take a highlighter and translate, okay, this is what they said, what do you understand? A lot of the parents, especially if they're being monitored by CPS, they're fearful of any authority figure and they don't want to ask questions, okay? And that ends up being very dangerous for the child. And so, so that's what we do through the program. But you really want to learn to listen to the patients and to the parents. You want to treat them respectfully. And even if they're being investigated by CPS or followed, we want them to know that they are the expert on their child, that we are trying to help them and we know that they are the expert, okay? You want to make sure that you ask for their feedback, that you're respectful, you give them access to relevant education, and you encourage the patients and their families to proactively participate. There has been more than one time that we've gone to look through a patient's chart and, you know, the students need some information and they said, well, it's not in the chart, you know, and then my response is, well, did you ask their parents? No? Okay, well, they probably know. Everything about that child is not in the chart, okay? So it's just really important that we really make sure that we're keeping them and including them as partners in care, okay? So as far as team, we expect you to have a team. Every team has to have a leader. Okay, it just, for teams to function efficiently, you really need to have a leader. And so we need to make sure that someone in the team is established as a leader. You want to identify the team's goals and vision up front early so that you can make sure you all have a shared mental model and assign roles and responsibilities. Okay, it's really important with a team that you hold all members accountable for their actions, that you have these actions and these assignments, you know, everyone knows what their role is, and that if they don't do what they're supposed to do, then you talk to them about it. I mean, the whole team steps and the whole team education, we all have to communicate with each other, and we hope that you learn how to do that better while you're in school, okay? You want to actively share information among the team members and provide feedback. Okay, so and this picture is just to emphasize, like, nobody knows where to go because there's nobody leading, okay? And that's what we have to have on our team. All right, so as far as leadership, effective leaders really do have to organize the team, articulate very clear goals, make decisions, and that's through collaborative and collective input from all the members of the team. Empower members of the team to speak up when there's something that they're not comfortable with, and to challenge when appropriate. actively promote and facilitate good teamwork, and we want to make sure that all the team members are very skillful at conflict resolution, okay? Because what happens, especially when you work with the same team of people, somebody ends up leaving really ticked off, and they don't say anything about it this time. It just festers and festers and festers, and then the next time when they get back, it's payback, okay? And all that ever does is really, I mean, it damages relationships, but ultimately it makes it a poor experience for the patient, okay? And so that's what we have to remember. I'll tell y'all a story. This was just a couple of years ago. I was at St. Joseph's. I had a group of nursing students there doing clinical, and it was very busy on the labor and delivery floor on the unit. And I'm an old labor and delivery nurse, and so I really like to go up to labor and delivery while the students are up there. And so there was this lady that was just like, I mean, she was just moaning and groaning. I mean, it just seemed like she was like in such active labor. I mean, it just seemed like she was just gonna have the baby right, I mean, at any moment, okay? There were all these people at the desk, and nobody really seemed to care. And I kept seeing this beautiful female just in her white coat just come out of the office, I mean, out of the room and go to the nurse's station. And then she would go back, and then she would come back, and then she would go back. And then, so finally I'm just standing there and I'm like, I need to go in there. Because, I was waiting on my student to come out of her room. I was trying to just, wait to get a report from her. So I finally went and I said, hey, can I help you? Is there something? And she's like, my patient's really hurting really bad. It was a resident. And she said, my patient is hurting really badly. And I said, okay, well, have you checked her cervix? Like it sounds like the baby's really come down. And she says, I can't find her cervix. And I said, okay, well, did you ask the nurse? And she said, she won't help me. Okay, so she had gone out to the nurse's station and said, look, I'm not sure about my exam. She's really hurting. I need someone to come and help me. And these are nurses that have been there for many years. And so what did they do? They said, oh, no, we're too busy right now. We're not going to come in and help you. They were punishing her because she was a resident. She had to come in and, gain respect, be worthy enough to work with them. Okay? So I said, okay, I'm going to check her cervix for you. We're just going to go right back in. I'm going to check her cervix. Okay. And what I ended up having, the lady had an extremely posterior cervix. So it was just really far up, way, way back. We ended up having to put her on a, you can put them on a bedpan, flip it upside down to like lift her pelvis up, be able to find her cervix. She was only 3 centimeters dilated. Okay. So, but I mean, this resident was in a panic because she thought, okay, I don't know what's going on, but this baby's probably about to deliver right here in the bed. I mean, the way the patient was just, just so verbal and so vocal. But those nurses, they were refusing to work with her just to punish her. And I'd never met her before, but she seemed like a very nice person, but it's just that, just not treating each other well, okay? So we've been doing that in healthcare for years. We've just been doing it for a really long time. So we're trying to get rid of that. And so I'm glad you were able to share some examples of what you've seen. And so I hope that you learned some techniques so you can kind of just like shut that down right in the beginning, okay? Okay, anybody else want to share anything that they've seen conflict? All right, okay. So barriers to team performance, kind of more of what we talked about, inconsistency in team membership, lack of time, lack of information sharing, like what we talked about. If you hold information hostage just because you want to have the upper hand and you want to hold on to that information, ultimately that's abusive to your team member, but also to the patient, okay? Varying communication styles. This is one thing that you will really see on the units when you have a lot of cultural diversity, okay, with healthcare providers. They may be someone that's very quiet and doesn't want to rock the boat and doesn't want to share information, all right? Or you can have somebody that's very vocal and overshares information and sometimes shares too much information in front of the patient about what's going on in the unit, like what you talked about with people arguing in the back room and they're out talking about all that in front of the patient. So just all different communication styles. Lack of coordination and follow-up, that definitely becomes an issue. Fatigue, and we don't work very many 16-hour shifts anymore. I know the residents do, but we used to always work 16-hour shifts, and at the end of a 16-hour shift, it's just hard to be patient with anyone, okay? And lack of role clarity and misinterpretation of cues. And so what we really want to do is teach you some different techniques that you can use as you go forward. Okay, so this is all from the Team Steps method that we talked about. And for planning, we want to make sure that you know how to hold what's called a little brief. All right, briefs are like little meetings that happen at the beginning of a shift. Depending on the acuity of the unit, it may happen mid-shift as well. But a brief is like you see your team members and you just pull them together for, hey, let's just talk about what's going on in the unit. Here's what's happening. This is something that's, a potential catastrophe, and we want to talk about it right now, okay? I'll give you an example. I was working at an urgent care clinic last weekend, And one of the other healthcare providers called in sick. And so I was the only person that was able to see adults there. And then there was a pediatrician, okay? And so he very calmly came over to me, because he got the call. He very calmly came over to me and said, hey, we need to talk about something. I'm like, oh, okay, what? Okay, well, there are actually 2 people have called in sick, and you're the only person that can see adults. And so it's about to get really hairy in here, and we're both going to be very overwhelmed, okay? And I know that I'm tired, and you're tired, and we're just going to keep from getting irritable, and we're going to be patient with each other, and because we know that we're both about to get slammed and really overwhelmed, okay? I mean, it was one of those things where it was just a small little conversation. It took 3 minutes, but it was like, we're on the same page. We know that it's going to be hairy. We know that we're going to be stressed out. They will all get taken care of when they get taken care of, and it's going to be fine. Something like that, I mean, that promotes mutual respect right there, because we could laugh about it later when we survived, okay? But we could laugh about it. We could say, we know that we're going to be stressed. We have a plan. Everything will work out, okay? All right. So as far as briefs, these are just little conversations. You talk about team roles, responsibilities, establish climate and goals, and you also engage the team in short and long-term planning. Another example of this is when there's a, like for instance, we had Allison, the hurricane or the tropical storm that came in. We had briefs all throughout the shifts to say, okay, here's how many patients we have that are being transferred over. This is what we need. And I mean, people were assuming all different roles, okay? I mean, housekeepers were taking vital signs in the hallway, okay? All different things, just to make sure that we really understood how we could help each other, and we really had an idea about how to move forward, okay? Okay, problem solving. This is similar to briefs. These are just little touch base meetings, ad hoc, where you can discuss very critical issues, anticipate the outcomes, and look at contingencies. Okay, if plan A doesn't work out, we're going to go with plan B. This is when you can assign resources and express concerns. What we call this is called a huddle, and this is just very similar to what happens in sports, where you get all together, you get your plan, and you go your separate directions. Okay, you're going to go out and you're going to take care of all the patients. Debriefs. This is what happens at the end of, say, a event. For instance, if you had a precipitous delivery, or if you had somebody code on your unit. Okay? At the end, you would get the care team together and talk about, hey, what went right? What went wrong? What can we do better next time? It's really important to have these after a Sentinel event, but really anything out of the ordinary, even if it's something that ends up with wonderfully, it's a great outcome. You still want to have that debrief where you get together and say, here's what we did right, so we can do it this way again, okay? Okay, so we want for team members to be able to work together well, and we do that with a couple of different techniques: situation monitoring, situation awareness, and a shared mental model. So for situation awareness, this is really a state of knowing about what's going on in your immediate surroundings, okay? So for instance, if you had a patient that was going down very quickly, you might have heard how different hospitals do different things, but there's a code team that would come, all right? In that situation, they're going to come over. If you have a patient that's going downhill, they're going to say, here's what we need. Here's how many team members we have. Here's what we need from your staff, okay? You just want to make sure that everyone has a very good understanding about the operational issues and things that could potentially affect the patient outcomes. A shared mental model, we've talked about this a little bit, and I think you have an idea about what it is, but what this really means is that everyone needs to understand the other's wishes and make sure that everybody's on the same page. Okay, and as far as feedback, there's different types of feedback. It can be constructive feedback or it can be evaluative feedback. And with constructive feedback, this is something that you all and all of us really should be open to as we progress on. Sometimes people get very offended when someone comes forward and gives constructive feedback, right? And so we have to really learn how to be open to this and to realize that if you take constructive feedback well, it can really improve the way that you care for your patients, okay? For instance, we do evaluations, okay, at the end of every semester. And last summer, I had it was a very, very busy summer, and I had 2 clinical groups. I was running all over the place. I was actually not being paid to work, so when I'm at faculty, I was just volunteering some hours. And I got my feedback back at the end of this semester, and one of my students said, oh, we love working with Ms. Pashinsky. It just seems like she's always in such a hurry. And I thought, that is absolutely right. I mean, they totally picked up on that from me because I was happy to be here, but I'm like, I'm very limited on my time. I have to finish my class and get out the door. And I didn't make myself available for giving feedback after class or, asking, soliciting questions and things like that. I had to own that. I mean, it was kind of, at first it's like, I can't believe they said that. But then it was like, well, they're right. I mean, I haven't, I am in a hurry. I'm in a hurry to get out of here. And they saw that and they interpret that as she doesn't care about being here with her class. Okay. So sometimes it's hurtful when you hear that, but you have to go, okay, yes, I'm going to be a little more calm at the end. I'm going to give myself 30 minutes after class to take questions and realize that, for me, it makes me a better faculty member. There are things that you're going to hear from your team members, even from your Press Ganey surveys that you may take it and say, golly, I can't believe they said that. But it's constructive. You have to take something from that and move forward. Okay. The other thing that we want to talk about is advocacy. This is really important. Right now, there's a big emphasis on moral courage. And what moral courage is you having the gusto to step forward and speak up about something that you believe is not right. Okay? And the reason that's important for all of you is that you are going to be new healthcare providers. All right, and so it's going to take a while for you to build up confidence to really speak out when there's something that is not right. All right, so we want you to realize that that's what you should do, but that it may make you feel a little bit insecure. It may make you feel like you're less than popular amongst the people that you spoke out against, but it's the right thing to do, and we really want to promote moral courage, and we want our patients to know that we'll speak out for them when something is wrong or something that is inconsistent or something that's harmful to them. You want to make sure, though, that you do assert yourself in a corrective, in a very firm but also respectful manner. Okay. Okay, so this is Interprofessional Healthcare Team. We have standards of professional practice, and that's what we all use to guide the way we care for our patients. Okay, so it's really important that although we want everyone to work together, we want to make sure that we have a good understanding of our own scope of practice so we don't violate and cross over any borders that we shouldn't. Okay. As far as abuse and neglect of children, in 2011, there were 676,000 children that were abused or neglected. That's a lot. Okay. Abuse and neglect can have consequences for children, families, and society that last a lifetime. We know more now about neglect than we ever have. I just went to a really interesting conference where they looked at MRIs of children that are in households with parents that are, specifically mothers that have postpartum depression that don't do a lot of interaction with their children. Those are children that grow up to have problems with reading. They have problems with verbal conversation. Some of these children have problems with ADHD. There's a lot to be said just about not so much that we have to abuse children, but just neglectful home situations. And so it's our role as healthcare providers to really speak to parents, really educate them on growth and development milestones, what they need to do to promote development in their child so that they can have the best life and the best health. Okay, so what are ethical implications related to providing education, care, services to parents that have temporarily lost custody of their children but will regain custody? Because in this specific case, the mom had left the children with the uncle, so they took all of her children away. She had 4 other children, including an infant. They took the children away. She had also had other CPS cases for leaving her children with other people that were not supposed to be around children. When CPS is monitoring a family, they limit children from having interaction from people that have felonies. Okay, so for her, they're very poverty-stricken family that has had a lot of interaction with the law. For her to leave, pretty much everybody in her family had a felony. Okay, everyone that she knew had some type of run-in with the law. So for her, she was violating her CPS stipulations pretty much every time she left them with a babysitter. She couldn't afford childcare. And so that was a real dilemma for her, okay? Okay, so these are different things that we want you to know about communicating with the families, with caretakers, with parents. We want you to be a good listener. show interest and concern about the family. Even if you have thoughts, preconceived thoughts in your head, you want to sit down and ask them, what happened? Tell me about the events that led up to this. Tell me about how we can help you to be successful in the future. What questions do you have? What are you confused about? This little boy had 2 surgeries, and it's in your case study too, but he has a lot of deficits now, and his mother is going to be taking care of him when he goes home. Okay, so what are the biggest questions that she has, her biggest concerns, her biggest fears? You want to make sure and check your face, okay? I have been guilty of that in the past too. You see something and you're just like, what? Okay, they react to that, they see that. We want you, when you talk to your patients, to sit down at eye level with them. If you're talking to a patient and they're sitting down low and you're standing above them, towering over them, it just gives them that feeling of, you are superior to me. Okay, we want to have open communication where they'll really listen to us and they really think that we're empathetic about what they need. Okay, and then also being aware of a comfort zone of people that you're visiting. Some people prefer very close contact. Others, they really don't want that very close contact. And I will tell you that patients that I've worked with, you just don't think about it. You go in, and I'm a person that I'm loud. I come up and sit right next to people. And patients that have been sexually abused. I had several patients that I took care of that were victims of sexual abuse, or women that were victims of rape. They can't take somebody just coming up and putting their hand on their knee or touching their arm. Or when I worked in labor and delivery, we would teach patients how to breastfeed their babies all the time. Okay, a patient that's been a victim of sexual abuse, they have totally different needs with the way we can touch their bodies. Okay, so you really have to be cognizant of how you touch them and what their parameters are. All right, you want to always ask their viewpoint. You want to be honest, but you want to also ask open-ended questions. You want to show empathy. You want to try to put yourself, think about how it would feel to be them. What would that mother feel like? Okay, you want to be patient. You want to allow the speaker time to express their thoughts completely before jumping in with whatever your diagnosis is or what their plan is or what they need to do to be better. Okay, you really want to try to listen with them. And I will tell you, it's a challenge for us. Okay, it's a big challenge. Why is it a challenge for us? Talking to patients and giving them time to tell you what their issues are. Why is that a problem? You have a lot of other patients, right? And if you work in a clinic, you have a patient scheduled every 15 minutes. So if you have somebody that you're really sitting and talking to, that's going to be behind for the rest of your day. So we really have to be cognizant and just try as much as we can to listen. Sometimes that means if they have needs that I know, I've sat in there with them, I've assessed them, I've talked to them for 15 minutes, and they're still having some issues they need to talk about. That may be with me getting them connected to a counselor, that we can get them someone to see soon. And that's something that's important too, about knowing other roles and other healthcare providers, okay, that you can refer to them to. Okay, so we want to maintain objectivity, offer choices or options when appropriate. Don't do all the talking. Don't avoid eye contact with your patient or with the speaker. Don't change the subject when the speaker is discussing something morbid or something depressing. And we've had this happen. Even a lot of our kids that we work with through CPS have incarcerated parents, or the kids have incarcerated parents, or the parents have had other children that have died. And sometimes I've seen whenever the mom starts talking to the students about her husband being in jail, and the students just like, okay, we're not going to talk about that at all. Okay, it's hard, and you ask open-ended questions. I always start with, oh, really? Well, how do you feel about that? How long has he been away? How much support do you have? Just those type of. How much are the kids able to visit with him? Do they have memory? Those most of the time, people, if they tell you that someone's in jail or they tell you that someone's died, they want you to ask a few questions about it. It validates the grief that they're going through when that person is not in their life anymore, or not living in their home, especially. Okay. Okay, so we want you to avoid being argumentative or critical. Avoid asking why or how come questions. It was, of course, we all wanted to know. You had those questions when you saw this 8-year-old that was shot. How could this happen? Why? Why were they left alone? In this case, working with CPS parents, we're going to educate them, but we've moved beyond the offense that actually got them there in the first place. You can't go back and change it, okay? So you want to move forward to help them to meet their health goals and be more effective parents. We want to make sure that you're not inattentive or insensitive to their concerns. And we also want to make sure that you are considering your role, and that you're not just there like a neighborhood friend or someone that they can just tell everything, all of their issues to all of you're there as a healthcare provider. You want to make sure that you have boundaries and that you maintain that professional role. Just to give you a little bit of an idea, because these are preconceived notions that we may already have in our own head, okay? What does an abused or neglected child look like to us? Down in this area in Galveston County, majority of the abused or neglected children that we work with have been Black or Hispanic, okay? It really doesn't have to do, it really has to do more with zip code than anything else, all right? Because when you look across the nation, there are the same number of children that are white as children that are colored, or the children of color that are in the foster care or in the CPS system. The numbers are the same, okay? So there's just things that we probably have notions, preconceived notions about just living in this area, what we've seen through the CPS program. If I'm out in Liberty County, completely different makeup of the kids that are out there that are being monitored by CPS, okay? So we just have to realize that this affects all communities, no matter race, gender. Poverty level is a big indicator for us, but we've had children that have been from very affluent families also that have been monitored by CPS. Okay, so we want to know how we can help. What is our role? The research shows that parents that have support from family, friends, neighbors, and communities are more likely to provide a safe home for their children. When parents lack this support or feel isolated, they are more likely to make poor decisions, and that's when neglect or abuse takes place. It's also important to know that children that are medically fragile, just by being medically fragile, they have an increased risk of abuse. Why do you think that is? Yeah, it's stressful, okay? If I'm taking care of a 6-year-old that's in a wheelchair that is a quadriplegic, and I have to do everything for him, if I have to bathe him, if I have to change him, if I have to feed him, if I never get a break for myself, am I going to be more stressed out? Yeah. And we've all had instances where we've said something that we shouldn't have said or snapped or been frustrated, okay? So just by having a medically fragile child, that parent is at greater risk, no matter where they came from, how much money they have, how educated they are. Just by having a medically fragile child, they're at greater risk of abusing their child, okay?
UTMB Health, working together to work wonders.